We are rapidly filling the rows in the auditorium, so we'll get started in a couple minutes. Alrighty. Still rising. So Emily or Brandy, how do you want to handle questions? Do they come through the Q&A?
They'll come through the Q&A, yep, and I'll be able to see them. I can just keep an eye out for them.
Okay. Because I don't know that I will necessarily be able to see those.
Yeah, no problem. I've got it.
Okay. I think we're going to let this get a little closer to 100 and then start up.
Sounds good. Yeah, it looks like we've slowed down. We can probably go ahead and get started.
Yeah, it seems like. So good morning, everyone. Thank you for attending Grand Rounds this morning. I have just a couple quick things I want to make sure people are aware of before we get started. First off, I think most of you may have seen by now that Governor Walz essentially relaxed the restrictions on elective surgeries, clinic visits, essentially reopening to some extent the hospitals and clinics yesterday. That doesn't mean we're going to take the tape down out of the waiting rooms and fill them up, but it does certainly give us the opportunity now to start bringing more patients back into this system. This is already happening on the surgery side. We started doing urgent cases late last week, and we've been able to facilitate that with COVID screening done preoperatively the day before. We'll be working on the strategies to actually essentially restore the clinic practice as well. The other thing that is happening this week is a group of faculty led by David Bernlohr in biochemistry is leading the reopening of the laboratory space. So we are certainly hoping to fill that space back up with productive research here over the next week or two. So all in all, good things are happening there. It's important that those things are done carefully and thoughtfully. There are policies and procedures you need to go through. You can't just show up at your lab tomorrow and start working. You know, get connected with Dr. Bernlohr, Dr. Panaskalsis-Mortari, you know, to make sure that we're going through the proper channels. So anyway, that's good news. Grand Rounds today is Dr. Emily Borman-Shoap. Dr. Borman-Shoap is going to update us on our education programs and the residencies. Dr. Borman-Shoap completed her undergraduate at Carleton College and then moved on to Washington University in St. Louis for her MD degree. She came back to Minnesota for her residency, was a very good resident as I remember her, and then was a chief resident. She then joined the faculty in 2007 and has been really engaged in our education programs ever since. She initially served as Associate Residency Program Director and then the Resident Program Director under John Andrews. And when Dr. Andrews left, it was a very easy choice to have Emily move into the role of Vice Chair of Education for the department. Dr. Borman-Shoap is a membership of the leadership team for education in pediatrics across the continuum. This is the national study that's going on to really redefine pediatric medical training. She's also leading local projects to enhance mental health training for pediatric residents. Dr. Borman-Shoap is an assistant professor for a few more weeks. She was successfully promoted to associate professor on the education pathway, which is no simple thing. So we're very pleased to have Dr. Borman-Shoap, and we'll turn it over to her.
Thanks, Joe. Well, I will share my screen in just a minute, just to orient those of you who haven't logged into one of our webinars in the past. We utilize the question and answer function. So if you'd like to ask a question, you can tap on the question and answer and type it in. I am leaving the chat window open. So if I say things that are interesting to you, Chat's asking about virtual video visits and face-to-face encounters. So I'm going to leave the chat window open. I may not look at that part as regularly during the presentation. So if you have something you want to be sure that I attend to, please put it in the question and answer. But I honestly personally enjoy a good chat with my colleagues who are attending a seminar, so I'm comfortable leaving that option open to you while I am talking, and you can chat with one another. But if there's something you'd like me to address, please put it in the question and answer.
I'll respond to chat.
Sounds good.
Let's go ahead.
All right, so let me get my presentation pulled up. All right. Hopefully everyone's able to see the screen. So I think being a decade landmark year, and perhaps because we've had some extra time to go on walks outside, I thought it was a good time to spend a little time looking back and thinking about the factors that have been shaping residency training over the past 10 or 20 years, and then think about what we might see going forward with residency training. You may want to mute yourself, Joe, just for lack of background noise. I don't have any disclosures or conflicts of interest. I will disclose I do not plan to talk about coronavirus or its impacts on education explicitly, but I'm absolutely happy to address that as a topic towards the end. I plan to leave plenty of time for questions and answers. So some of the things I wanted to be sure to talk about is really thinking about what are those factors that shape residency training, and some of these may be things that you would expect, some may be things that you would not necessarily expect. Spend a little time thinking about what's coming next, both from a national accreditation standpoint and some of the things that we're interested in locally. And then I'm going to share with you guys just a snapshot of some of the things that we use to try to keep track of how things are going in our residency program. It's definitely not a comprehensive list of the kinds of things that we're looking at here, but just a chance for you to get a glimpse into the kinds of data that we use to help inform our decisions. So like I mentioned, I can't see you, of course, so use the question and answers. I will imagine a rapt audience with hands raised, ready to ask lots of questions. I'll try to pause after each section and see if there's specific questions pertinent to what I've been talking about or about other things. And then towards the end of the talk, we'll open it up for kind of broad ranging questions about whatever's on your mind regarding residency education. So some of the sort of large forces that shape residency training that I thought it was worth spending some time on are financial, accreditation, and healthcare workforce supply and demand. One of the things that certainly has struck me as I've moved farther up the administrative ladder and spent more time taking on leadership roles is you spend a lot more time talking about the money than you would wish to, but it's the reality that people's salaries need to be paid, and there are operating costs and all the practical backing behind the great work that we want to do usually requires money ultimately. So it's important to understand the flow of the money, where it comes from, how it might change over time. So this is the world's briefest review of residency and fellowship funding, GME, Graduate Medical Education Finance. And really the model that we have now was initially put in place in about 1965 with big Medicare overhaul in this country. And as a part of that large Medicare bill, they laid out the sort of broad framework for funding for GME. And it's tied to hospitals where residents work, and it's tied to the Medicare funding that that hospital receives. So it you could have many conversations about whether that makes sense or not, but those are the genesis of how GME is paid for. There's two components to the funding that hospitals receive for GME funding. So there's what are called direct costs. That's the direct money that supports a resident's benefits and salary. And then there's what are called indirect costs. So the extra cost of paying to run a training program. So program director's salary, a residency coordinator's salary, study materials, in-training exams, professional memberships, many other costs beyond just the salary of a trainee are a part of the cost of running a training program. So there's two elements, the direct and indirect costs. And those are capped based on the number of residents that a training program is training. So if you listen to people talking about their residency number, you'll hear people say they're at cap. And what they mean is that the number of residents that they can claim reimbursement for from the federal government is set at a certain amount. That initial number was set in 1996. So, 25 years ago. Certainly quite a bit has changed in the healthcare landscape since then. With the advent of the Affordable Care Act, there has been some ability to petition to adjust cap. There also was a lot more risk to, quote, lose cap. So they had some specific language about kind of use it or lose it. So if you were approved for 100 residents, but you only billed for the services of 97, you may not continue to be able to bill for the services of 100 residents in the future. So it's a quite complex system. It also tends to reinforce the current structure of having residents do quite a bit of their work in a hospital-based setting or in a clinic that is attached to a hospital, because that's the work that can be reimbursed by the federal government. I do want to be really clear that the vast majority of hospitals employ and train residents well above their cap from the federal government. So our hospital systems have made investments in our training program beyond what they're able to bill for at a federal level, partly to meet state workforce needs, specific training needs in a profession. There's a lot of factors, but I would say it is a rare hospital that is not spending money above their cap. Interesting nuance for us within pediatrics is there's a separate pool of money called CHGME funding, because pediatric patients are not typically on Medicare, and so that funding model that's tied to Medicare funding doesn't really pertain to pure freestanding children's hospitals. So that's a different pool of money that's managed slightly differently, that has some certainly benefits, but it also means that that funding can be at risk in different ways. So if you hear people talking about CHGME funding, that's what they're talking about, is the funding for trainees who are at freestanding children's hospitals. Looking at our local environment, I think many would probably be aware of this, but just to explicitly state it, the majority of our University of Minnesota residencies ultimately rely on financial support from multiple institutions, not just financial, of course, educational support, and really teamwork across our whole community to support the number of residencies that we train. And there's a kind of collaborative council called the Minnesota Metro Council on Graduate Medical Education that really came together. It's probably been in some form for about 20 or 30 years now, to help all of our different sites who host residents kind of have a conversation. Here's where we are, we're at cap or not at cap, here's how many trainees we're going to support in the next academic year, and to really kind of share best practices and how to make those decisions. It certainly was a group that did a lot of the recommendations about how to keep track of resident effort. It probably led to the extremely detailed duty hour logging that we're not doing anymore, thankfully, but many residents will have memories of logging their duty hours down to the half-hour increment with very specific locations, and that all really related to our need to demonstrate that they were doing work at the place where they said they were going to be doing work. So there's some local factors that may not be shared by all residency programs because of the fact that our training programs are partnerships between multiple institutions. As I mentioned with the Affordable Care Act, there have been some kind of minor changes in the ability to apply for increase in cap, but the main kind of bones of the model with direct and indirect payments, having it be based on a cap, really hasn't changed for many, many years. There was an Institute of Medicine report in 2014 that really made some sweeping recommendations about how to change GME funding, and it didn't get much traction, but the general concept was to establish a base payment rate for training programs, and then to hold out what typically would have been the indirect funding and encourage people to use that money for innovation or really needed training programs. I think overhauling all of GME payment is a Herculean effort that would take a lot of lobbying and energy at the state legislature. So I'm not real surprised that it hasn't taken off, but these are conversations that bubble up from time to time at the federal level. And it's certainly also something that is talked about at the state level. And I think we've been quite fortunate in the state of Minnesota that our state legislature really gets it. I think they've really, we've had some great champions at the state level who understand the limitations that the current federal funding for GME places on training programs. And so probably starting about 6 years ago, the state of Minnesota set aside a few different funding streams to support additional training slots or additional training initiatives. One was the primary care expansion grants. and another was the International Immigrant Training Grant Fund. And our pediatric residency program has been quite fortunate to be recipients of both of those grants for 5 years in a row, and has really brought in a significant amount of additional funding into our department. So about $2.7 million in funding over the course of 10 years. And that's allowed us to do some of the flexible things that we really wanted to pilot with our EPAC program, for example, and has opened up other new opportunities. So I think as we look to the future and think about how we can modify residency training to make it more flexible, or trial different types of rotations that are more community-based or more outpatient-based, we may need to continue to look to funders that aren't our typical funders to help us do training in a different way that isn't so tied to the usual funding streams. Okay, I will pause there briefly and see if anyone has any questions they would like to ask about residency funding. I think the Q&A thing will light up if somebody has a question. Okay, great. All right, I'm going to move on to another deeply exciting topic. Apparently, when a program director has quiet time to go for a walk in the woods, they think about budgets and accreditation. So perhaps I need to work on what comes into my mind during my free time. I think anyone in the room who is involved in residency or fellowship administration, you can't help but get a little skipped beat when you see ACGME. That's our accreditation body for residencies and fellowships. And, I think that, yes, they require us to do things. Yes, they regulate us, but they also really shape the work that we do as educators. And there's no better way to shape the training programs than to force them to do things. I think sometimes we may have ideas of changes we'd like to make, but the inertia can be difficult. And I think having the regulations and the requirement of a governing body can give a program director or an educational program the kind of strength they need to push for changes that they may need to make within a hospital system or a program. So this is, kind of feels like old hat for us probably. We've gotten really used to thinking about duty hour limitations, but they really have not been in place for all that long. So people started studying and thinking about the impact of long hours of work on, well-being and patient safety, even in the late 70s and early 80s. An ACGME working group had formed and started to have conversations in 1988. Right around that same time in 1989 was the formation of what was called the Bell Commission in New York. It was prompted by the tragic death of a young woman, and it was thought that fatigue and unsupervised trainee work may have contributed to that poor outcome for that family. And so the state of New York was really a leader in pioneering some duty hour limitations and set the stage for a national campaign to limit duty hours. It did take quite a while, so those duty hour regulations didn't actually go into place until 2003. And you can see them there. They're sort of what you've come to know. Some have gotten a little more stringent over time, but you have to have at least one full day off per 7-day period, averaged over 4 weeks. You can't do 24-hour call more frequently than every third night. The 80 hours per week, averaged over 4 weeks, and more explicit supervision policies. So those rules went into place probably in the late sort of 2008, 2009, 2010. There were a number of studies that tried to look at differences between 24-hour shifts and shorter shifts. Certainly kind of mixed evidence because it's quite hard to study, but I think it's good common sense that working for 16 hours in a row instead of 24 is probably better. They did not go so far as to limit work hours for all trainees. So in 2011, they limited the work hours for just first-year residents to 16 hours. At that time in our program, we elected to just make that change. In the vast majority, we have some rare shifts where people do 24-hour shifts still, but the vast majority in our program, one of the things that was really important to us is maintaining team structure and maintaining that partnership between the senior resident, who's the supervisor and teacher, and the first year resident. And so that was really the time when our program made a major shift from the kind of classic every fourth night 24-hour call to doing day shifts and night shifts. They actually ultimately rescinded that 16-hour rule for first year residents because of the challenges that programs had with fragmentation and problems with frequent handoffs and being challenged to structure their teams when first year residents had different rules than second year and third year residents. So the duty hour regulations are incredibly important. They, I think probably haven't gone far enough, but it's what we have right now. I think we're still thinking and learning how to build schedules that are more livable, and this is sort of the minimal acceptable standard. We certainly learned a lot in the first, many years of duty hour regulations about how to build resident schedules. And I think one of the things that was really clear to us is that trainees are really committed to high quality patient care, and they really want to make sure the right thing happens for patients and families. So if you build a schedule that is going to require them to run out the door the second they sign out, they're probably going to have duty hour problems because they're not going to run out the door. They're going to make sure their patient gets what they need. They're going to make sure their colleague understands the sign out list. And so we need to build schedules that have more cushion built in and more flexibility so that your schedule as written doesn't bring you right up to the limit of your duty hours. So I would consider duty hours to be a minimum standard, and there's probably much more that we need to be doing, and I'll talk about that a little bit later. One of the things you will hear people talk about as we talk about modifying schedules and modifying the way that residents engage in their clinical work is finding kind of that balance or that sweet spot. So as you modify a resident schedule, you may end up really altering the way that they interact with the other team members. And so just really being mindful of trying to find that balance where the residents are integrated on a team, they're relied upon to some extent for patient care and really critical in moving patient care forward, but they're not so critical that everything will fall apart if there's not a resident there that day. And I think that's a balance that we've found really well on some of our rotations, and we're still working towards on others. Another big element of the ACGMEs, this is sort of the big umbrella. So they started with duty hour regulations back in 2003. And at that time, you would maintain your accreditation with what was called a site visit. So the ACGME would physically come to your site about every 4 to 5 years, and you'd be called upon to create this huge dossier of materials with logs of patients seen and rotation evaluations and many, many binders of materials. And there was a lot of sort of gamesmanship of programs trying to make their program look good on paper, and not as much ability to kind of be open and honest about the things that were going well for your program and the things that you'd like some help with. So starting in 2013, they moved to what they call the next accreditation system. So instead of having these sort of large high stakes visits every 5 years. Now on an annual basis, the review committee for the ACGME looks over all of the materials for a residency program and makes a recommendation either for continued accreditation. They note if there's areas of concern, or if they have significant concerns, you may be issued what's called a citation. So the elements of that reporting are the milestones, which I'll talk about. And the ACGME doesn't look at what rating you assign to your residents, but rather that you are completing the milestones reporting. There's a survey that the ACGME sends out to residents and faculty in your program every year. And then as the program leadership team, we update a considerable amount of information into what's called web ads, the Web Accreditation Data System, every summer, which includes data on the scholarly productivity of our trainees and our faculty, new projects that we're working on. If there were any areas of concern or a citation, you address those. So it's an opportunity to be much more current with things that you're working on and new projects that are in place in your program. And the ACGME has a much more frequent sampling of the resident experience and faculty experience in your program. So the annual survey of residents is where they have the ability to share with the ACGME if they are experiencing problems with duty hours or the learning environment. So that's really the data that the ACGME uses to make its decisions. Again, I hope the milestones are a concept that is familiar to most, but just in case they aren't. So the milestones are the American ACGME's version of the broader movement towards competency-based medical education. So moving away from simply spending a period of time in medical school or residency, being offered a sort of menu of learning opportunities. You work hard for a period of time, and if people feel that your work is adequate, you are able to graduate. The problem with that system is if you don't explicitly describe the competencies that you feel are important for trainees to have when they finish their training, you may end up with gaps in certain areas. And a lot of the work of competency-based medical education is to more explicitly describe all of the competency domains that really are critical to being an effective physician. So it's not just being efficient at patient care or having a robust medical knowledge base, it's also being a gifted communicator or having high professionalism ideals or being skilled at systems-based practice and quality improvement. So the milestones were launched in 2013. In pediatrics, there are 21 different areas. They have descriptive terms for the level at which you designate that you think a trainee is performing. In true pediatrician fashion, the descriptions were quite wordy and lengthy for each of the levels. And so a lot of the work that we did when they were first rolling out is to try to help our faculty create a mental picture of what it would look like for somebody to be having performance that matched that level for a given milestone, and really worked on having shorter descriptions for each of those levels. So one of the things that really happened for us when the milestones came out is we took a good hard look at how our faculty were evaluating residents. And at the time, I can remember putting up a slide at the division directors meeting and just said 6%, which was the amount of evaluations that faculty had completed that had been assigned to them. So we had a lot of trouble with evaluations not being filled out in a timely manner. Our evaluation form was really much too long and cumbersome. And so we did a lot of work making our evaluations shorter and easier to understand. We really narrowed down our group of evaluators. So now on each rotation, there's a core evaluator who gathers feedback from all of the people our resident may work with, and then they submit a summary evaluation at the end of the rotation. So that way we have a more consistent group of people who are filling out evaluations, who really create a kind of shared mental model about what performance we're expecting and what the competency domains are. That milestones also require that you have a clinical competency committee. So that's a group of people that meet at least every 6 months to discuss the progress of all trainees in the program. And I think it's really helped us to identify areas where we don't have enough information about trainee performance, or to really think about who has that information. So there's some aspects of a trainee's performance that their peers are best suited to tell us about. There's some aspects that a member of the interprofessional team is best suited to tell us about. So it really kind of started that thought experiment for us about where do we gather the information and how do we gather the information. Really the next phase in thinking about how we assess residents is the concept called the entrustable professional activity. So anyone who's spent some time looking at the milestones in pediatrics, one of the things that's always been a little disheartening to me is the word child or family is hardly present in any of those milestones. So the milestones are not very specific to pediatric training, but they are these sort of elemental skills that help you to be effective as a pediatrician. So you do need to be efficient and organized and be able to put together a differential diagnosis to be successful as a pediatrician, but then can you apply those skills in this specific clinical setting? So the EPA kind of gets at that idea. It's a professional activity. It's a thing that you do, and the person who's supervising you basically can assign a supervision level. They can say, hey, you've never done that before, so you just watched me do it. We did it together. I had to double check a few of the things, but you did most of it. I was at home, you called me just in case, or you're so advanced in your training now that you actually supervise someone else doing that skill. So you can imagine that, you know, if you are seeing a resident, you want to know, can they take care of a newborn baby? Can they go to the nursery? Can you trust them to have the medical knowledge to understand about risks for hyperbilirubinemia? Do they have the communication skills necessary to talk with a tearful mother? Do they understand the systems and how to plan for discharge? So EPAs are kind of the direction that we're moving in to really understand how do trainees take the kind of foundational competency skills that they have and put them into action in specific care activities. The American Board of Pediatrics has really kind of helped to outline, again, people might quibble with the list, is this the right 17 EPAs? It was a really thoughtful group of expert educators who came up with the list, and you can see that many of the core activities of being a general pediatrician, caring for a well newborn, doing acute care in an ambulatory emergency setting, medical home for well children, you know, recognizing patients with surgical problems. So thinking about, you know, if somebody can do all 17 of these core skills independently, they're probably pretty ready to graduate and be ready for independent practice. All right, so those are some general thoughts on accreditation, assessment, some of the factors that may shape our curriculum and how we give feedback to residents. I'm going to talk just very briefly about healthcare workforce supply and demand, mostly because I would say it currently actually does very little to inform each other, and that's probably an area for future work. You know, we are opening some new medical schools in this country. Admissions have gone up slightly, although not significantly. Residency positions haven't changed very much, partly because of that cap problem we talked about earlier. But at least in pediatrics, there are absolutely more than enough residency positions for applicants from US medical schools. But the students rightfully are trying to look out for their own best interests as they apply for residency, and they kind of get one shot at it. So they want to try to ensure that they match successfully. So over the past several years, we've really seen a phenomenon where students are applying to way too many schools. And so we as the receiving program are getting way too many applications, and it makes it really challenging to try to understand how to do the recruitment and selection process, because it's a different problem. 7 or 8 years ago, we interviewed the majority of candidates who applied to our program. That's absolutely not possible now. We get 600 US applicants for our 24 spots. So I think it's really caused us to think about, how do we do interviews? How do we help people understand if our program is a program they should be applying to? And certainly down the road, thinking about what happens after residency. At least currently in our medical system, there's not very much feedback to say, gosh, we need general pediatricians. The people who graduate should go into general peds. We need endocrinologists. We got to push people into endocrinology. Right now, for the most part, we've really allowed people to pursue a career that they're interested in, which is certainly how it should be. But I think there's probably some room for us to consider if someone would be equally happy being an endocrinologist or an emergency medicine doctor. Maybe we need to find ways to encourage people to go into the field where there's a shortage, or at least make sure their options are well known to them. So I'm hopeful that that's something that we may see more of down the road, is creative solutions for encouraging our trainees to go into fields where their work is really needed. All right, so I'm going to move on and talk briefly about just some things that we're thinking about locally, some things that you'll see on the national landscape in terms of area of interest, and then share with you some of the data that we use, just a few snapshots of different dashboards and metrics that we use. These probably won't come as surprises because they're things you hear us talking about all the time. So well-being and resilience, diversity and inclusion, healthcare disparities, mental health training. Locally for us, we've been working hard to establish our physician scientist pathway, and certainly both locally and at a national level, there's continued interest in making our patient safety and quality improvement training more robust. Some of these areas have really been more explicitly called out by the ACGME. The training programs all have specialty-specific requirements that are laid out by your specific subsection of the ACGME, called the RRC. And then there's what are called common program requirements, so requirements for all trainees in the residency and fellowship level. And there's a lot more language in the new common program requirements that are going into place this July about requirements to really have good plans in place to recruit and retain a diverse workforce, to make sure that our trainees are adept in describing and addressing healthcare disparities, quite a bit of language about supporting trainee well-being. So it's something that all programs are going to be working on, and certainly work that we're doing locally. So I'm going to touch specifically on well-being and resilience, diversity and inclusion, and then at the end I'll talk a little bit about the mental health training program that we're working on. So as far as well-being and resilience goes, one of the things we really realized is if we're going to try to make things better, we have to know where we stand. There's a national study through the Association of Pediatric Program Directors of about 50 pediatric and med-peds residency programs. We've participated in that cohort since its inception 4 years ago. It's an incredibly lengthy package of surveys, so it includes the MASLAC burnout inventory, has demographic data about what kind of rotations you've been on, questions about sleepiness. There's an Epworth sleepiness scale that people fill out. So there's just tons of data, and it really has been helpful for us to understand how is our own program faring over time, and then how do we compare it to other programs across the country. Starting 2 years ago, the ACGME also added some questions about well-being to their annual survey. Those aren't a part of your accreditation decisions currently, but I can imagine that they may become so at some point. So just again to reiterate, if so we're all on the same page, what we mean when we say burnout: emotional exhaustion, depersonalization, so that sort of sense of going through the motions or almost a sort of out-of-body experience, and then a lack of sense of personal accomplishment. So it's different from depression. It's not depression. It's a specific set of symptoms that are related to the workplace. So this is a snapshot of the reports that we get back from our participation in the Burnout Resilience Consortium. So the teal colors are all residency programs across the country. So this is 16, 17, 18, 19. This is first year residents, second year residents, and third year residents. And then the kind of peachy orangey tones is our University of Minnesota Pediatric Residency Program. So you can see that in general, our first year residents are about the same, or perhaps slightly better than the national average. I would say our second year residents tend to, again, be about the same, maybe slightly better, and our third year residents are maybe worse, maybe better. The first year we participated in this survey, we had a sort of low response rate because it's so long. A couple of residents teased us and said they got burnout just from filling out the burnout survey. So we were like, oh, it's so great. Our third years are really not experiencing burnout. But then in subsequent years, when we really encouraged people to fill it out, it was clear that that number was really much higher than we would want it to be. And even though we're perhaps around the national average of those who are participating in this study, I hope we can all agree that having a third to a half of our workforce feeling burned out at any given point in time is absolutely not where we want to be, and is clearly a sign that there's more work to be done. Oh, somebody raised their hand. Let me see if I can figure out what to do about that. I think I can let you ask a question. Let's try that. Did that work, Muna? Were you the one who raised your hand?
That was me. I was trying to do the Q&A, but never mind me. So my question was about in 2018, why do you think the percentage of residents with burnout increased in all 3 years compared to the other years?
Yeah, I don't know. Maybe it was a bad year. Yeah, I think it, you know, certainly one of the things that we know is that I think we are, can be lifted up by our colleagues, but if we're all kind of collectively going through a tough time, it can feel almost contagious. And so I think that one would have been at the end of the first time that we did what some of the stuff I'll talk about in a little bit with all class retreats. But I think it's nice that we have 4 years of data now, because it just varies, you know, a moderate amount from year to year, and it's clearly quite dependent on survey completion. And I think that someone who is going through a tough patch at work, I think, is probably less likely to fill out an extremely lengthy burnout survey. So that's the reason why we really encourage all of our residents to fill out the survey, and really would like them to be honest about how they're feeling when they fill it out, so we can understand where we're coming from. But I don't particularly remember any significant changes we made that year. There were a lot of schedule coverage problems that year, which I know is really taxing for the residents to have their schedule changed or be pulled in for extra coverage. So, you know, all these things would be conjecture or association, but I think that's something that we'll be able to look at over time and try to understand what might influence burnout. Yes, Angela Panskaltis-Mortari asked if it correlates to faculty burnout. We did burnout surveys for our assistant professors about 2 years ago, and the levels were quite similar, kind of that 40 to 50% range. I'm not aware if we've done MASLAC inventories for our faculty at all levels, and we haven't done it in a while. So I think that certainly would be a good area for future study, or to create kind of a dashboard for our department. We do this survey in April. So you could wonder about, you know, seasonality of burnout and when it may happen as well. And we don't have that data right now, but certainly studies of faculty burnout, Tate Schonefeld and Lottie Derby out of Mayo do a lot of the work, and they've looked across all specialties, and pediatrics does tend to be lower, which is great, but that sort of point prevalence of, you know, sort of 40 to 50% is not uncommon. All right, thanks for those questions. So last year, the Resilience Consortium had enough data to start to present some of their findings. They are not surprising probably, but again, just highlight that structure informs function, and really thinking about the way that schedules and vacation and the simple act of having a weekend off can have a significant impact on burnout. So for example, they asked residents on the survey, what kind of rotation are you on right now? So kind of higher acuity or busier rotations. Residents reported 50% burnout versus 43% no burnout on those rotations, versus lower acuity rotations. 57% were not burned out, and 50% were. Being longer since your last vacation, longer since your last weekend. Those were all things that had a significant difference. One of the things I thought was an interesting finding is if someone reported being involved in a patient where there was a major medical error seemed to contribute to stress and burnout. So that's another area for us to attend to, certainly, over time. One of the things that sort of looking at that data from the Burnout Consortium and really trying to better understand just the experience of given rotations, we really revamped our end of rotation surveys this past year, and that's the exact question stem. It just says, rate your ability to maintain work-life integration. Going to have a whole side conversation about the concept of work-life balance or work-life integration, but that's the terminology we used on our survey. 5 would be the resident endorsing that their ability to do so on the given rotation was outstanding. 1 would be totally unsatisfactory. I find overall that it's quite uncommon for our residents to give low ratings. So once we get below the midpoint, that is tends to be a real red flag for me. So I think it's going to be data that will help us to really look at rotations and say, well, you know, what is going on about this rotation? Is it the hours? Is it the work that they're doing while they're there? Is it not flexible enough? What are things that we can do to improve the experience? So each of these columns is a rotation. So this is the average rating that residents gave to their ability to maintain work-life integration while they were on a given rotation. This is, don't expect you to read all of these, but just so you know the kinds of things that the ACGME is asking on their wellness survey. Do you find your work to be meaningful? Do you have enough time to think? Are you engaged? Is your work a positive challenge? We're close to the national average, but in a number of categories, we're slightly below the national average, really in the majority of categories. I think, again, that's just areas for us to really look at, you know, what does this mean? What do we need to do to make this better? So some of the things that were, blue team raised hand. Let's see if I can let you guys talk. Blue. Okay, blue team, let me see if I can hear you. Unmute. All right, blue team, I think you'll be able to talk if you'd like. Oh, they don't have a mic. Do you want to, did you put it in the question typing? Okay, great. I think Angie had a question. I'll let her.
Like they put it into the.
Yeah, they're putting it in the chat.
Yeah.
Yes, that national average is for peds. Thanks for that question. Angie, did you have a question that you wanted to ask? See if I can get you unmuted here.
No, I'm sorry. I accidentally.
Oh, there we go. Accidental hand raise. Okay. Mute. Yeah, be careful. I'll call on you if you accidentally raise your hand. The numbers on the well-being are not very different for peds versus all comers, but I compared it just for peds. I put this little clip in here mostly for my own entertainment. We'll see if it works, but you know, really the thing that has struck me over the years is I think our residency program and many others have been a sort of feast or famine phenomenon where you're on a really difficult inpatient rotation, you're exhausted, you're cumulatively tired, and then you finally make it to your elective or outpatient rotation and you reconstitute yourself. So one of the things that has always struck me is you should not be able to just look at a resident and tell if they're on an inpatient rotation or an elective by how tired they look. So that is my goal. Our ultimate metric will be that we don't have to reconstitute them and kind of build them back up after such difficult inpatient stretches. All right, I can see that I'm getting close to the end of time, but I do want to just share a little bit of data about what we're doing to try to recruit a more diverse workforce. We're working with several of the other residency programs, internal med, med peds, family medicine, psychiatry, OB. We've put forth a proposal to the central GME and the dean's office to invest in recruitment efforts for bringing in a more diverse workforce. It's really there are some, I don't know if you could call them best practices, but there are things that are certainly happening across the country that we'd like to be doing, like visiting electives, second look weekends. And then we're really trying to pay attention to it. So we're trying to pull out the data about who applies to our program, who do we offer interviews to, who comes, who cancels their interviews and doesn't end up coming, and who matches with us. The other thing we need to look at is if we recruit a more diverse workforce of people with varied lived experiences, then they need to be able to practice in a supportive environment. So our GME office has internal surveys, and one of the things that we're really realizing is many of our trainees are experiencing both explicitly offensive remarks from patients. That's really the biggest offending group. There are what I would call never events, where they're experiencing comments like that from faculty. And then microaggressions, so the not so explicitly stated, but certainly equally troubling interactions where someone is made to feel uncomfortable or undermined because of who they are. So it's something we're paying attention to. We're starting to have conversations, but I know that we need to do more. Again, we added questions into our end of rotation survey, trying to understand, is it in the patient care arena, and do you feel like you can contribute to the team? Is it in less formal settings where those problematic interactions are happening? So trying to gather lots of data about trainee experience. Just briefly, because I'm really proud of this group, we have a kind of a grassroots group that includes myself, Katie Cullen, who's the child psychiatry division director, Andy Barnes from DBP, Jerica Berg from family medicine, Sherry Friedrich, who's the director of the Peds Nurse Practitioner Program, Katie Steingraber, Amanda Schlesinger, and John Homans are from psychiatry. Katie Lindgren is from psychology, and Betsy Murray from DBP as well. So this group has been meeting together for about 2.5 years now, really brainstorming about how we can help our pediatric trainees be more comfortable in addressing common emotional and behavioral health needs in the clinic and hospital setting. And we're hopeful to be able to launch some additional training within the next academic year that perhaps will be the topic of next year's Grand Rounds. So that is time, I realize. I want to be respectful of our time limits. Certainly if there's questions, I'm happy to stay on and answer a few more questions. Thanks to everybody for your participation today. Certainly saw lots of residents on the board. They're probably wanted to make sure I didn't launch some crazy new plan from the Grand Rounds platform. Yeah, just have a great day, everyone.
All right, well, thank you very much, Emily. Yeah, we are a bit over time, so please feel free to email Emily, and we'll, I guess you can leave this open for a little while afterwards. So Emily, I had a question myself. Years ago, as we were working on the new criteria for evaluation of residents, there was a series of videos done that actually demonstrated people progressing through the entrustable activities. Are those still used?
We haven't used them very much lately, mostly because our group of core evaluators has been quite consistent over the years, and we have found that kind of our best shared mental model comes in the clinical competency committee, when we're able to kind of talk with one another and describe what we mean when we say this is this level. But I think those training videos can be very helpful, and certainly as you're onboarding new people.
Yeah, that's what I was wondering, because if they don't get pulled up every now and then, we kind of turn over the faculty, at least 30 or 40% of the faculty every 5 years.
Yes, absolutely.
Yeah.
Looks like maybe, I can't tell, Brandon has his hand raised on purpose, but Brandon, did you want to ask a question?
Yeah, I had a quick question for you, Emily. Thank you. That was a great review. The question I had was about the upcoming interview season for residents and trainees for our fellowship programs. and sort of what discussions that you've had to this point. There's been some interesting discussions about maybe producing some videos for people that can't travel to visit our institution or the Twin Cities, and kind of where things were with looking at remote interviews or using Zoom for interviews for applicants.
Yeah, we are really starting to start those conversations in earnest. The Association of Pediatric Program Directors put out a quite comprehensive set of recommendations for how to approach, really more focused on residency recruitment, but trying to really focus on equity, recognizing that some trainees may be affected by COVID differently than others. And so the costs of travel may be even more burdensome this year than they would be other years. So I think it will be wise for us at the fellowship level to be actively thinking about how we could do some sort of Zoom or virtual interviewing. And we're really looking into what that might look like at the residency level as well. We've definitely talked about trying to make some videos highlighting the strengths of our program. I think we all feel like getting people here and seeing the beauty of Minnesota and meeting the people in person is of course our preference, but if that's not available to us, how can we recreate some of those things? I suspect there'll be some things that we can make that would be shared across the fellowships and the residencies, and you guys need them sooner, obviously, because fellowship interview season is going to be starting up within the next couple of months. So I think that's something that we're going to have to really ramp up with in the next couple of weeks here.
Emily, there's a question from Marissa Hendricks about microaggressions. Can you think of a way to get specific feedback to faculty who are perpetrating microaggressions?
Yeah, it's there are several avenues. It's something that it can be a challenge because many times the whole reason it's a microaggression is the person doesn't realize that they're doing it to some extent. If they knew they were doing it, that's just being explicitly offensive. I think some of the mitigating effects in real time are some of the training that our EDIC group has offered on how to be an ally. So I think having somebody who's able to step in real time and either provide a course correction or real-time feedback is incredibly helpful. And often the person who has sort of suffered the microaggression isn't really in a position to make that course correction for the person. But if there's an ally or a supportive colleague who can kind of pull someone aside, I think that's often the best. There are anonymous reporting systems that we really encourage the trainees to use that get fed to the Office of Student Affairs, and they will follow up on things. Children's actually has instituted a specific reporting system just for microaggressions or other problematic treatments. I have worried about how to help a trainee to share their concerns, but not have them be worried that it will come back to be negative for the trainee themselves in some way. So I think that's a conversation I would very much like to continue having with our faculty, is how can we create a supportive environment and commit to being open to feedback. If we say something that we shouldn't have said, we need to be ready to make it right. And I think that is a big part of it. So there are a few different avenues right now. None of them are working perfectly. And I think it's something we need to keep paying attention to. Absolutely.
Okay.
Thanks for that question. All right. Well, I think we should probably wrap up, but I really thank everyone for their attention today, and hope you all have a great day.
Yep, thank you, Emily, and we will catch you all next week.